This program is brought to you by Emory University.
All right, good morning, everyone. We have a nice treat today, and that we're going to talk about vascular biology stuff. That's good stuff. And just the fellows, just to warn you, when you take the boards, I think I remember some of this stuff showing up on there, and it may not be things you see every day in your practice, or maybe you're seeing it every day in your practice and not aware. But today we have a team. I told Khusrow we had to bring in some support here. I will leave any derogatory comments about interventional cardiology out of it. But brought in some support here, working with our colleagues from rheumatology. And I'll start out, Khusrow will introduce everyone, but this should be a very helpful talk for us to really think about inflammatory vascular disease. So,
Thanks, good morning. When I signed up for this grand rounds, I started thinking, what should I discuss? And this case came to me. And through this case, I was introduced to some outstanding people. And one was Karen and one was Dustin, and they've been very willing to participate in this grand round, so it's an honor to have them over here. Karen is also program director of internal medicine residency over here. She's a great rheumatologist who somehow heard about me about doing some case from one of her colleagues, and she calls me up with the patient, and that's the patient we'll be discussing. I'm going to have Dr. Dustin Staloch present the history on this patient, and then we'll have Karen discuss the medical aspect, and then I will show the angiograms and what we did on this patient. So Dustin, please.
So thank you, Dr. Niazi. I'm going to be presenting a case today of a large vessel vasculitis and use it to accomplish three things. First off, we'll discuss when to suspect a large vessel vasculitis in your patient and some of the diagnostic challenges there. Dr. Law is then going to help us review the medical treatment options before setting up Dr. Niazi to discuss endovascular management options. So our case begins with a chief complaint of hypotension. The patient's a 30-year-old African-American female with a history of iron deficiency anemia, who presents to the cardiology clinic on the heels of a hospitalization where she presented with syncope, and admission there was predicated on her hypotension at the time. So she says she last felt well around August of 2014 when she began to feel increasingly tired every day. 6 months later, in February, she presents to her PCP and is diagnosed with a microcytic anemia with a hemoglobin of 8.1. And her PCP refers her to hematology, whose initial note comments on her menstrual losses and the high platelets to be probably related to an iron deficiency. They check a ferritin, that's 169. And they also do a bone marrow biopsy. And the pathologist in the biopsy report says, this is an interesting and unusual anemia. While many parameters may point to iron deficiency, others do not, notably her low total iron binding capacity. Furthermore, marrow shows stainable iron and serum ferritin is normal, pointing against iron deficiency. Nonetheless, she gets iron supplementation, and perhaps in retrospect, this was a chance to consider something else was going on, given that that initial note even mentioned 17 pounds of weight loss over the last 6 months, unintentional, and recurrent fevers over this time period. Nonetheless, she carries on and 2 months later begins having headaches with floaters and is said to have ocular migraines. Fast forward a year to April 2016 when she's walking around her home, and in the kitchen she begins to feel transient or just very briefly lightheaded, collapses to the floor and awakens moments later. She presents to an outside hospital ER where vitals are checked, and she's noted to be hypotensive and tachycardic. Upon standing, when they checked orthostatic vitals, her heart rate rose to 137 for a presumptive diagnosis of orthostatic hypotension. So she receives fluids with albeit minimal and transient improvement. As such, they pursue alternative diagnoses, getting a contrasted CT of the chest to evaluate for PE, but that's normal. CT of the head is normal. And the note from the emergency department mentions a recommendation for admission to medicine for workup of an endocrine issue. But she actually finds herself admitted to the ICU for 6 days, on and off of a norepinephrine infusion, and on the receiving end of a battery of imaging and consults. I mentioned the CT chest and CT brain. Early in her ICU stay, the neurology team saw her and got an MRI of the brain and C-spine, which were normal, an MRA of the head and neck, which were largely unremarkable, if not for some limited interpretation due to contrast timing. She's seen by a cardiologist in the ICU, whose exam notes a 2/6 systolic murmur, but no bruits, good pulses. They check an echo with normal systolic and diastolic function, no valvular disease or effusions, and ultimately even get a stress test, which is not abnormal. And finally, recommend an evaluation for something like a pheochromocytoma or adrenal pathology or carcinoid. The workup for all of that being normal as well. Ultimately, she's transferred out to the floor where a discharge summary just 1 day later notes her to be looking well, feeling well, and ready to go home. And that's what she does with recommendation to increase her salt intake, her fluid intake. She's given a prescription of metoprolol and recommended an outpatient tilt table test. But just 1 month later, she presents to the cardiology clinic on the prompting of an astute nurse that had commented that while her blood pressures are low in the arm, the pressures in her legs are actually 100 millimeters of mercury higher. In clinic, despite increasing her salt intake, despite increasing her fluid intake to over 10 glasses of water a day and not taking the metoprolol, she feels worse. Everything over the last several weeks has worsened. Her dizziness and blurry vision with standing are now near daily occurrences. She's still losing weight. She can't exercise or do her yoga because she says she gets pains in her arms with minimal activity. And again, she recounts her daily fevers about a year earlier when she first started feeling bad. In the cardiology clinic as well, there's difficulty getting blood pressures in both of her arms. And given the progression of symptoms and hypotension in her extremities, she's admitted to her service. Physical exam there notes blood pressures in all extremities, with the exception of the left upper arm, which had trouble even getting a pressure. But in the right arm, she's 56/42 and 148/80 in the right leg. Despite these pressures, she's maintaining normally. She said to overall not look unwell or uncomfortable at all. And in fact, much of her exam is within normal, if you exclude the loud bruits over both sides of her neck and chest, and if you exclude the fact that both radial pulses are faintly palpable, while those in her legs are normal. At this time, vasculitis was already on the differential. So inflammatory markers were checked, and both are elevated, the ESR at 48 and the CRP at 136. At this time, the team got vessel imaging. And we have here an MRI of her neck with and without contrast. And Dr. Niazi will discuss much of the findings in better detail. But turning the attention to the left subclavian, we see a full occlusion distal to the offtake of the thyrocervical trunk with distal reconstitution. And furthermore, the right subclavian with severe disease, both carotids with severe disease, long segment, and the vertebral here on the left, difficult to appreciate, but similarly with disease, as is the vertebral artery on the right. So at this time, she was seen by rheumatology and diagnosed with a large vessel vasculitis, namely tachyosteoarteritis. And at this point, it's important to note when we talk about large vessel vasculitides, we're really talking about two diagnoses, tachyosteoarteritis and giant cell arteritis. And while diagnostic criteria exists for both of them, there's really a significant phenotype overlap, and both are characterized by granulomatous inflammation of the aorta and major branches, leading to adventitial thickening, intramural hyperplasia, driving stenosis and lumen compromise. Differences do exist. As in our case, tachyosteoarteritis is said to have a more insipidus presentation, which can be tricky in diagnosing. whereas giant cell arteritis has more of what we're used to hearing, the new onset headache, sudden vision loss, an acute or subacute presentation. It's important to note, though, that while we can note the involvement of the temporal artery with giant cell arteritis, that's not off limits in tachyosteoarteritis. And similarly, in temporal arteritis, half of cases have extracranial involvement. And so really, diagnostic criteria for both exist, but the biggest difference is the age at diagnosis. Whereas in tachyosteoarteritis, we talk about an onset of symptoms under age 40. Giant cell arteritis is favored in those who present over age 50. But still, the challenge here is that these are both very rare diagnoses, with giant cell arteritis winning out by a little, occurring in up to 25 cases per 100,000 patients annually, whereas tachyosteoarteritis, especially in the US, is much more rare. Reports indicate that between Europe and the US, there's less than 3 cases per million patients annually, versus in Japan, where there's almost, by some reports, up to 150 cases annually. So rare diagnoses, certainly this is not necessarily on the differential for any patient with hypotension or elevated inflammatory markers. And the key here really is keeping it on your differential and remembering, at least for me, how this patient presents, which is pretty common for vasculitides such as this. Symptoms often start with long-standing systemic complaints, with our patient demonstrating fevers and fatigue and weight loss over a course of several months. But you can imagine with vague complaints like this, they can go underreported or misattributed in her case, or across the board fairly under-investigated. As such, disease can progress unchecked to the point where patients ultimately present with symptoms related to hypoperfusion and end organ effect. So in giant cell arteritis, this is the classic jaw claudication that we talk about, or in this case, or any large vessel involvement of extremity claudication being fair. And in our patient, a predominant amount of cerebral symptoms for dizziness, syncope, headaches, and vision changes. At this point, some of the signs related to the disease are going to be more apparent. Inflammatory markers are probably elevated. An exam is going to note probably a pulse differential and bruise, pending vessel involvement. Now, none of this is to cast blame. These are rare diagnoses, and the patient in question here was seen by upwards of a dozen physicians that had all overlooked this. But I can't help but point out that there are salient points here that were missed. And really, again, the chief challenge here is keeping it in mind, because I'd like to believe, one, that those bruits didn't pop up in the course of a month, but I've read through every note in her chart, and not one person mentioned them in the last 18 months. But I think should you consider it, someone who earnestly were suspicious for this could stumble across the 1990 American College of Rheumatology criteria for classifying tachyosteoarteritis and find these six criteria. For her, checking the box for age of onset under 40, her limb claudication, her diminished pulses, and her systolic pulse differential and bruits over her subclavian arteries. Already she's checking 5 of 6 boxes before we even get to her abnormal angiography. And if we note that the presence of more than 3 of these to be highly sensitive and specific, keeping it in your mind and keeping it on your differential can prompt a more directed questioning and exam, which for her hopefully possibly could have led to earlier imaging, earlier diagnosis, and earlier treatment. But it's a challenging diagnosis to make, and even therein more challenging to treat. So at this point, I'll bring up Dr. Law.
Okay, so I'm going to echo what Dustin said, that although we typically describe Takayasu as having an insidious presentation, I actually view that as meaning that we have more of an opportunity to make that diagnosis. I don't typically have cardiology fellows in my clinic, but I have tons of rheumatology fellows, residents, and students. And this patient has now gotten so accustomed to having learners come and evaluate her that she will readily point out all of the salient features of her cardiovascular exam and, exactly where to put the bell of the stethoscope to listen for the bruits, et cetera. And I think the reason for that, and what I use her as a teaching case for, is to emphasize to our learners that we get very blasé about performing certain aspects of the cardiovascular exam or certain aspects of the physical exam in general, because 99.9% of the time, when you listen for subclavian bruits, they're going to be normal. But in this patient's case, especially when there was so many other clues that something was not right, if someone had just performed that exam, they would have been clued into some of these issues, or if someone was thoughtful about her pulse exam and the pulse differential between the upper extremities and the lower extremities, or even pushing that a little bit further. I was sort of buoyed when I read the ED consultation about, or the inpatient consultation saying that she should be evaluated for pheo or carcinoid. It's not that vasculitis needs to be on the top of every differential, but clearly something else was going on. And clearly, as primarily trained internists, there were features of her physical exam that had one person looked into. And in her case, it was a nurse who said, I think I've heard about this. There's something weird about you. Why are you so hypertensive in your lower extremities and hypotensive in your upper extremities? There may be something that is blocking the blood flow, and I'm not sure what it is. And that's the only sort of that's the level of knowledge that you needed to have to be clued in that something else was happening. So management of large vessel vasculitis, this is a challenging disease. Early diagnosis is difficult. There are no standard or reliable parameters of disease activity. There's no standard imaging modality, but I'll go through what each of the imaging modalities lends us in just a minute. And then it's a very rare disease, obviously. And we have no ideal outcome measures. And there are obviously no randomized controlled trials. So there are only open studies, case series, expert opinion. In this case, I have consulted with colleagues at the University of Pennsylvania, and they sort of agree that she's quite a challenging case. So it is not as though you could open up to date and it will give you sort of the handbook on how to treat this patient. So a word about imaging modalities as you're evaluating these patients for Takayasu's arteritis. So imaging is very important in this disease. It helps us to establish the diagnosis. As Dustin said, angiogram is one of the ACR established criteria for making this diagnosis. It helps us to determine the distribution of lesions, especially because in these patients, for this patient, primarily she was having upper extremity claudication as well as some presyncopal symptoms. So a lot of stenoses that are in the upper areas of the aorta, but she actually ended up having multiple lesions scattered throughout all of her large vessels, both above and below the diaphragm. And then also helping us to monitor for disease activity. However, and as a rheumatologist, I live in the gray, so there's never any kind of statement that is sort of definitive. Selecting the right study is challenging, and the findings are not always reliable. So again, I bring you back to the fact that this is a very rare disease. We have no randomized controlled trials. All we have are open case series. And so all we have are just a collection of patient stories, essentially. For every patient where we say, this imaging study showed that this patient was in remission, we'll have another patient who has an imaging study that improves, but then, 5 days after they have the imaging study performed, they have a huge flare-up of their disease. So the gold standard is, or was, I say, angiography. And as you guys saw and Dustin presented, for the American College of Rheumatology's diagnostic criteria, they include angiography, but they don't include other modalities. And I think that's because now these other non-invasive modalities have become a lot more sophisticated since the time of the establishment of the criteria. So, the challenge with angio, it only shows lesions that are affecting the vessel lumen. So the larger lesions, probably the ones that are causing bruits, but it does not show non-occlusive lesions, and it doesn't give us any information about the vessel wall and the degree of thickness and inflammation in the vessel wall. So non-invasive options can now show us earlier phases of disease, like where we see the vessel wall thickening, some indicators of mural wall inflammation. And then later, as the patient has been treated, and again, we're only now sort of collating this data into case series, you will see homogeneously thickened vessel walls and some luminal changes that will help us to know that this is a later form of the disease. And so each of these imaging modalities that I'm going to go over has their pros and cons. So ultrasound has the highest resolution, but the most limited views. You can pursue a TEE in these patients, and that will give you a little bit better of a view. But again, we talked about how this patient ultimately ended up having lesions above and below the diaphragm, and so accessing those areas and diagnosing those areas can be difficult with ultrasound. MRA and CTA, lower resolution than ultrasound, but you get a better overview of the vessels. You need to consider your radiation exposure, especially if you choose CTA as your primary diagnostic modality. PET scan can indicate inflammatory activity and active disease, and for any of you guys who have ordered a PET, you will always get the disclaimer from the radiologist that they cannot distinguish what the etiology of the inflammation is. Obviously, in patients like this that we've obtained PET scans in, where they concentrate the primary inflammatory activity in the walls of the vessels, in the absence of other sort of infectious vasculitides or other things, then we feel pretty confident in saying that the PET activity is due to inflammatory activity from the rheumatic vasculitis. But you also cannot delineate the vessel wall structure or luminal flow, which can be helpful. So PET-CT can be combined. This is not very widely studied, but it can give us better anatomic information, obviously. But then we have to consider that radiation exposure is very high. These are typically young patients who will receive a series of these images over their lifetime. And so again, it's something for us to consider. So for management of large vessel vasculitis, in addition to the imaging, there's many other things that we need to do to try to suppress the inflammation once we've made that diagnosis. And so I'll give you a page from the rheumatologist playbook. For any of you guys who have ever consulted rheumatology, this playbook should be familiar to you, the rheumatologist approach in 3 simple steps. So achieve rapid control of inflammation with corticosteroids. Takayasu's arteritis is typically quite steroid responsive, but relapses are common with steroid tapering, and it's a challenge because the inflammatory activity usually lasts for 8 to 12 years. And so this is not a period of time, especially in a young childbearing woman or a young woman of childbearing age, where we want to expose her to 40 milligrams of prednisone daily for 10 to 12 years. And then there are long-term adverse effects from the steroids, as I mentioned. So, once you have achieved immunosuppression with steroids, then you want to add conventional immunosuppression. The goal of that is to slowly titrate up some kind of disease-modifying agent so that you can then achieve a reduced dose of steroids. So the best data is on methotrexate. That's probably because it's the oldest steroid-sparing agent that we have. And by best data, I mean that there is one series reporting 16 patients. 81% achieved remission and 50% maintained remission. So often methotrexate is one of the first medications that we reach for. The challenge with methotrexate, again, this patient is a young woman of childbearing age, and methotrexate is contraindicated in patients who are planning family planning. Smaller series suggest the efficacy of azathioprine, cyclophosphamide, and mycophenolate as well. And I think the general consensus among expert opinion is it doesn't actually matter the type of immunosuppression, you just want to add an additional agent. And then number 3, consider biologic agents if number 1 and number 2 do not work. And so I've really just shown you the secrets of my entire repertoire for most of the patients that I see, which is to add steroids for immediate immunosuppression, consider a pill conventional immunosuppression, and if that does not work, consider biologic agents. So thinking about biologic agents, Takayasu's arteritis is primarily thought of to be a T-cell driven disease. The cytokines that T-cells secrete tend to stimulate macrophages and granuloma formation. And so that makes T-cells, antigen-presenting cells, and TNF-alpha promising targets for treatment. Meta-analysis of 20 case series of TNF inhibitors in Takayasu's arteritis reported an 89 to 100% initial response. However, relapses are still common, less common than in the case series for methotrexate, but still common at 37 to 62%. And most patients will require a decrease in the dosing interval or an increase in the dose to sustain a response to these agents. A more recent meta-analysis of 14 case reports and a couple of small case series shows that treatment with TNF-alpha inhibitors plus methotrexate achieved an equally robust response and that 40% were able to discontinue prednisone. So this speaks to how we understand biologic agents to be incredibly effective, but they themselves have an immunologic effect, and it is very person-specific, but each person, individuals can develop antibodies to the biologic agent itself. And so adding methotrexate in many of these patients helps to blunt some of the allergenic effects of the medications. So should anti-TNFs be used earlier in treatment? These are some of the remaining questions that my colleagues are looking at. It sort of follows the paradigm of rheumatoid arthritis and many other disease categories that we take care of, where there's a lot of reluctance to embrace biologic agents simply because they are unknown. And it doesn't, I'm not advocating a cavalier approach to these medications. They certainly do have a lot of long-term adverse effects, many of which we don't fully understand currently. There's a black box warning for malignancies, especially lymphoma and melanoma. For rituximab, there is a black box warning for progressive multifocal leukoencephalopathy. And so they do have their own risks, but have been extraordinarily effective in a space where our conventional immunosuppression has not been. And then there's promising new data for tocilizumab, which is an anti-IL-6 receptor antibody. It's been used in some case series of really severely ill patients in the hospital who have achieved prednisone-free remission within 6 to 12 months of initiating the therapy. So once we've decided on, once we have agreed that this patient has Takayasu's arteritis, and we have started the patient on both some kind of corticosteroids as well as some kind of other immunosuppression, what do we do to monitor for disease activity? And this is sort of the remaining question that has yet to be answered well. So improvement in symptoms and inflammatory markers is reassuring. There are challenges there. One is that not every patient's inflammatory markers are as responsive as one would hope, and they may not mirror the improvement in clinical symptoms. The other challenge is that, especially as we escalate to using biologic agents, many of these biologic agents themselves interfere with inflammatory markers. And so, for example, if you have a patient on tocilizumab, you specifically cannot use inflammatory markers to monitor for disease activity. As I mentioned earlier, relapses can occur without warning, and they can be quite severe. And then, as I also mentioned, imaging is unreliable. So, we look at vessel wall edema, mural contrast enhancement, FDG uptake, and that does typically improve with successful treatment. And then if we see a decrease in wall thickening, it indicates that you've achieved some kind of sustained control in months to years. But for every patient who follows this rule, we have had experiences with multiple other patients where either their imaging or their clinical symptoms continue to improve, but then we are sort of surprised that they develop a large-scale relapse very soon after. So back to the case, the patient was diagnosed with Takayasu's arteritis. As Dustin presented, she ended up having all of the 7 criteria that we look for to diagnose Takayasu's arteritis. She was started on 1 mg per kg per day of steroids, in addition to mycophenolate. And again, mycophenolate was selected primarily because she's a young woman of childbearing age who had thought that she may wish to pursue pregnancy sometime in the next 5 years. For those patients, I typically try to avoid things like methotrexate, which have a long half-life and are difficult to, are unreliable to wash out. By day 2 of steroids, she had no further dizziness. It was actually quite a remarkable improvement over the course of 48 hours. She's afebrile. Her blood pressure was measurable in both arms, though when she was discharged from the hospital, her systolic blood pressure was somewhere in the 70s. So it was still quite low, but was measurable, and she was not symptomatic. Her radial pulses were much more prominent, and her inflammatory markers showed improvement. However, her hand claudication was persistent. She described this, I remember, on a Sunday on 4G, where she finally got out of bed and went to the shower. And as she was shampooing her hair, she began to notice that she was having some tingling in her hair, and so that muscle pain with activity that she reported was still present. Also, when she was brushing her teeth, she felt like there was some tingling in her upper extremities along with some pain. So the hand claudication was still present. And so we discharged her from the hospital, but knowing the extent of the vascular lesions that she had, this patient probably 10 to 12 years ago would have necessitated a consultation with CT surgery. And so, what this case has taught me so much is how much our interventional cardiologists can partner with us and how much more in the upcoming years. I suspect that management of this type of case will require partnering with our interventional cardiologists rather than with our CT surgeons for bypass procedures, et cetera. And so for that, I'll pass it over to Khusrow, who can tell us about his approach to her care.
Thank you, Karen. Well, that's a phenomenal job, Dustin and Karen, you have done. And I would like to stress again the issue, especially for the fellows, when you're seeing these patients in the clinic, try to examine them from head to toes. I call it H2F, head to foot care for heart and vascular disease. In fact, some of you have been to my clinic, all my new patients, they have to wear these paper shorts. And it's just mandatory. Otherwise, I won't see the patient. And some of them like them so much that they have taken them home. Well, we trash them. So I tell them, if you want to take the paper shot, that's fine. So I've put a question mark because I really don't know where we are heading and if this is even the right treatment. And you will see some of the thoughts that were going through my mind and some of how we have treated this patient. It has really taught me something. Because before this, I had another patient who was also referred by a nurse practitioner who had listened to one of my talks, and that lady had been going on for 6 years and was told, never get your blood pressure checked in your upper extremities, just get it checked in your legs because your upper extremities are not reliable. And she had bilateral subclavian occlusion, and she had giant cell arteritis. But these are my disclosures, actively involved in drug-coated balloons in the research, and currently we have started another trial with Surmodics. So that may affect my presentation because I will be talking about drug-coated balloons. This has been classified, the disease, as I think Justin mentioned, it's far more common in the Asian countries. So they do classify, Nomano's classification came late in the 90s, where they explain that if you have disease involving the arch vessels, that's type 1. And you can have arch vessels and the aorta involved or the thoracic aorta. And then you may have sparing of the arch vessels, but just the aortic involvement and the renal arteries. And then you can have below the diaphragm, or you can have all the arch vessels, aorta, and the renal arteries, and the iliac arteries involved. Mostly that what I've, in my limited experience, I've seen this category, but we do check the renal arteries. When I was looking at different studies, trying to see if there's any data to support about endovascular, this was out of Cleveland Clinic, where they looked at the data from 2004 to 2009 and published it. And they were looking at stent grafts, stents versus stent grafts. But they were talking about the old treatments of either balloon angioplasty or just plain stents. And as you can see, the restenosis rates and the occlusion rates were, pretty high. So it wasn't a promising treatment strategy. And they were looking at stent grafts. And in their data, they thought the stent grafts did a little better, but did not solve the problem. This is coming out of Turkey. Apparently, the disease is very common in Central Asian countries and Afghanistan, Turkey, Iran. And this paper was published by them. And they looked at it, and as you can see, they have only 18 patients over there. So not a whole lot of experience, but everybody's trying different strategies because many times these are young patients, and they don't want to expose them to major surgery. And again, the patency rates are not that great. You have to do repeat interventions to keep these vessels open up. The most important thing is that we all are realizing that we don't want to intervene when the disease is active. When there's active inflammation taking place, we don't want to go inside the vessel wall and start putting in metal or ballooning it or traumatizing it. We want it to be quiescent. And that's where I think I was asking Karen, when can I take this patient to the lab? But you have to tell me. And I learned one thing which I didn't know, that MRA can tell inflammatory thing besides the inflammatory markers. But the problem is that these are not very sensitive. I mean, this was a surgical study where patients were going open surgery and they were taking vessel specimens. And they found that the patients who underwent this procedure, open surgery, were thought to be quiescent by all the non-invasive testing. 40% had active arteritis. So we are still doing surgery or endovascular treatments on patients when there's active inflammation taking place in the vessel wall, and we are not sure if that is the right strategy. And maybe that's why we are failing. That's why our endovascular results are not looking that good. Anyhow, coming back to this patient, when we see patients in the vascular clinic over there, ultrasound is our best friend. I mean, we do tons of ultrasound. And this was her right subclavian artery in July when I saw her. And you can see the peak systolic velocity is 460 centimeters per second. Normally, your peak systolic velocity in the subclavian should be somewhere around 70 to 80 centimeters per second. So just for the fellows, I mean, if you're taking boards, these questions do come in the boards, as Bob was mentioning earlier. About 15% of cardiology boards are vascular. And you see this continuous flow in diastole. In an artery, you should have a triphasic nice flow, narrow waveform, negative pulse, and then a positive waveform, and that's a nice triphasic. This is a low resistance waveform, which we really see in the internal carotid artery when which is supplying the brain, which is a low resistance waveform. But over here, you can see the subclavian artery, a lot of color aliasing. I can't show you the real video because the patient names pop up. So this is her right common carotid artery in the proximal area. The right common carotid artery velocity 583 centimeters per second. Normally, it should be somewhere around 60 to 70. And your diastolic velocity is 304. Normally, that should be 30 to 40. And you can see this continuous diastolic flow. This, without even knowing the velocity, just looking at the waveform, you can diagnose there's significant obstruction. This was a left subclavian artery, no flow. So obviously the hand is on this side, the origin of the left subclavian, there's no flow in the left subclavian, collaterals filling the distal left subclavian. And this was a left common carotid artery, again at the proximal end. It's very hard to check the ostium because they are thoracic. So with the transducer above the clavicle, it becomes challenging. But this is what we could detect, that a velocity was 649 centimeters per second and a diastolic velocity close to 300 centimeters per second. We did check the renals and the renal arteries, both right and left renal arteries. They had nice waveforms and the velocities were not elevated at that time. So we brought her to the cath lab and we did this angiogram. This is an arch angiogram. And what you are seeing is the innominate artery, the right subclavian artery has a channel, and you think that this is the right common carotid artery. But this is not the right common carotid artery. This is the right vertebral artery, which has an ostial stenosis here. This is the right common carotid artery. And it originates right over here, and you will see it in some of the views. This is the left common carotid artery. I mean, this looks more like an anterior tibial artery in diameter. This is the left subclavian artery, and it gets occluded here. And you will see in a late filling of the distal. This vessel is an anomalous origin of the left vertebral artery. So we had a little gift given to us that it wasn't arising from the left subclavian. It gave us in the treatment option the different, but you can see the ostium is again diseased over here. And this is an RAO view, again showing you the right subclavian artery, how tight that is. This is the ostium of the right vertebral, and this is your right common carotid artery, the thread-like structure over here. And this is the left common carotid artery. And this is a distal filling of the left subclavian through the thoracocervical trunk collateral. This left subclavian is missing in this segment. And this I showed you in real time. There's a challenge over there. Once we took these pictures, I mean, my concern was, what are we going to do for this patient? So I came out of the cath lab and I called our vascular surgery colleagues and I talked to them at length about this. And they came over and they say, you know, she's 30 years old. I mean, if we expose her to any major surgery right now, she's going to have repeated trips. What, can you do something? And I said, well, you know, I mean, we can give it a shot. And then we had to decide how are we going to approach this thing. So I realized that she's very ischemic in the brain. I mean, the vertebrals have osteal disease, the common carotids are diseased. So what should I do first? Well, I need to first monitor her blood pressure, what we are doing. So I said, let's go for the left subclavian artery. Now, whether that's the right technique or not, I don't know. But these are just the carotid angiograms. We'll come to them later on. So we came into the left subclavian artery. As you know, you have to get a guide sheet over here. So we had to, and I won't waste too much time. I know they are non-interventionalists. They will say, you know, the guy is just, this is the ostium of the left vertebral artery coming from the aorta. So we brought her back on September after we talked to the patient. We took her off the table. We brought her back and talked to gave her the choices, and patient agreed for endovascular. So we brought in a 6-French sheath by anchoring a wire into the thoracocervical trunk. And using escalation 014 wires and stiff wires, we were able to cross this lesion after putting a crossing catheter through it. And we were able to dilate this thing. My fear was, with this inflammation going on, will I rupture this vessel? I mean, I had experience with atherosclerotic vascular disease. I really didn't have much experience treating inflammatory type of vascular disease. Though Karen had given me the assurance that, you know, inflammation is controlled, go ahead. So we used a special balloon. It's called a chocolate balloon. It has a cage on the outside. And in my experience for the past 3-4 years using it, causes less dissections. So we came in with a smaller diameter, 4 millimeter long chocolate balloon, just to get an idea of where's the lesion, found the lesion, dilated that lesion, and then we took a picture and we realized, okay, this is the segment of disease that we are dealing with. And then came in with larger chocolate balloons, dilated that, and finally touched this up with a drug-coated balloon. No experience in inflammatory disease. What does drug coating does? I mean, we have looked in the literature, and Dustin has been trying to publish this paper, and he cannot find too much experience out there. What would the drug do in this type of disease? I wish we can put drugs that rheumatologists like, and not paclitaxel for atherosclerosis, but something else to inhibit this thing. And this was a result on the left. So we were happy. It wasn't perfect. I didn't want to put a stent in there because my concern was metal in an acute inflammatory disease process might create more problems. She came back after a month, and we said, okay, now we need to address her cerebral because I can at least monitor her blood pressure. So we can monitor her blood pressure, and we went after the left common carotid artery, and we had to just leave our sheath hanging out in the aorta, and we were able to get an 014 wire and then get a distal filter. Before I did this case, I called some national leaders in carotid disease and stenting and asked them, and I said, what's the role of drug-coated balloon? And they frightened me. They said, if you use it and 5 or 10 years down the road, patient has some intellectual impairment, she can come back and blame you that your drug coating did damage to her brain. So I backed off. I said, okay, there's no data. I won't use a drug-coated balloon in a carotid. And we came in, this was a carotid, common carotid artery. As you can see, the bulb region looks good, the internal looks good. So dilated it with a balloon, chocolate balloon. This is the filter going up. I won't waste time with that. And after the balloon, this is how it looked like. But this is not a diameter of a common carotid. This looks even smaller than the internal carotid artery. So I knew if I leave this over here like this, will I give her much benefit of cerebral perfusion? So I said, fine, let's put in stents. Now, we do have drug-coated stents, but again, staying away from drug coating in a cerebral, though later on I've talked to some other people and they've used drug coating and they've gotten away with it. So we came in, placed self-expanding long stents, covering throughout the common carotid artery. And once we had the stents expanded over there, it was very hard to expand one area, which was right over here, and patient would just not tolerate the pain with the balloon. We wanted to push these stents as much as we could, but this was the final balloon inflation over there, and this was how the result looked like, but you can still see there's some constriction here. But I was afraid also, not because only of the pain, that if there is inflammation over there, will I make the situation worse? This was our REO projection of the left common carotid artery. After a month, we brought her back, and we said, now we will address a left vertebral anomalous and the right subclavian artery. So we treated the left vertebral artery ostium with a plain balloon, again, not a drug-coated balloon, but it was again a chocolate balloon, and we were able to avoid stenting that area by just dilating this area with a balloon over there, and this was how it looked like after a balloon. And we moved on, and we went ahead and treated her right subclavian artery. And again, the same strategy. We came through the right radial artery because I wanted to protect the ostium of the right vertebral artery. As you can see, the right vertebral artery is diseased. So my plan was to come from below and wire the right vertebral artery with a filter, come from the right radial artery, which was hard to see because these vessels become atretic almost, small caliber when you have proximal occlusions. And once we had both wires and filter placed, then we were able to do a kissing chocolate balloon in both those vessels. And we're able to get this angiogram. And finally, I placed a drug-coated balloon in the right subclavian artery and treated that with a drug-coated balloon. And this was a final result of her. This is a year later. You can see the velocity was 460, and now a year later, her velocity is 565. But the waveform doesn't have continuous diastolic flow. It is imperative that when we treat these patients, that we follow them with arterial duplex, because if the velocities start going up, it's better to treat this disease, in my thinking, early on than when they get 100% occluded again. So when we saw this thing, we said, okay, she's restenosing. Her right common carotid artery, in fact, improved without any treatment. And this gave me thought, would I have waited another year on this patient? Would these arteries start opening up themselves? I mean, the reason I'm saying is if you look at the velocity of the right common carotid artery, originally was 583. It's remaining stable, 540. The diastolic velocity has come down from 300 to 183. You can see the lumen is a little better than at baseline without treatment. This is the left subclavian artery, which has gone also again, no flow, now has 398 centimeters per second peak systolic velocity. Again, not normal, but you can see there's good flow, there's good lumen over there. And this is the left common carotid artery, which we had stented. The waveform is far better, still a low resistance waveform. Velocities have come down to 229 from 650, and the diastolic velocity has dropped down to 68 from 300. So I told her that we should not wait. We should go ahead and treat the right and left subclavian artery again. And we brought her back, and we treated the right and left subclavian artery with larger balloons. We were able to push up our balloon diameters, created a larger lumen. And she just followed a couple of weeks back, and you can see her right subclavian artery is 298 centimeters per second, which was 565. And we brought that down, again treating with a drug-coated balloon. And in the left subclavian, the velocity is now 209. So she is now 5 months post-intervention. And we'll keep following her every 6 months with arterial duplex. This is the left common carotid artery. We are keeping an eye on this thing because I have a feeling if this starts getting worse, we will have to go back and touch up the stent over there. But when we did the angiogram for the subclavian, we did an angio of the left common. There was a 20 millimeter gradient, but I left it alone, and I said, let's wait if the left common carotid artery stent gets worse. And the right common carotid artery is really the one which has interested me because I didn't treat this thing. And it was a thread-like over here, and it has kept on improving. And that's why I'm asking myself this question. If we can delay this treatment and let the medicine and inflammation and the edema subside, will that be a better form of treatment rather than sending them to surgery? Though I know in some patients, if they're symptomatic or if they're developing critical limb ischemia or gangrene or something, or cerebral hypoperfusion. So I talked to our neurology colleagues, and I said, should I open up the right common carotid artery? And they said, well, let's do a Diamox MRA test. So I had no idea about, and they explained me. Basically, Diamox vasodilates the cerebral blood vessels. And they said, let's see how much baseline vasodilatation she has post-stenosis, and does she have a reserve that she can dilate more? That would mean that the right doesn't need, and the left vertebral flow, the right vertebral flow, and the left common carotid artery is providing enough blood flow. So we did that in November last year, the Diamox MRA, and that suggested she is getting good blood flow. There is reserve on the right side. So apparently the circle of Willis is protecting the right cerebral hemisphere from the left common carotid artery and the two vertebrals that we had treated. So we did not. And this is, I think, the take-home message for me, that if you look at the autoimmune diseases, that how many physicians does it take on an average before the disease gets diagnosed? And how many get labeled, unfortunately, as chronic complainers? And the number of years it takes. If we can identify this disease, I understand it's a rare disease, it's not common, but I think there's still no reason, for us to, keep this in our back of our mind and listen for some bruise, supraclavicular, and just checking for pulses would give us a good idea. So I think for the fellows, asking the right question is important, and the fellows are too young to remember this one, but some of us might remember that. So I think asking the right question is the important thing. So we have 5 minutes for questions, and I would really again like to thank Karen for an outstanding job and Dustin for a great presentation. Thank you very much.
That was great, and a great team presentation. I'll start out with I have to have two questions, I guess I have to ask. So the first one is really to Karen and Dustin. So in the criteria for TA, there's no systemic marker there. And is that, so, all of us sort of fear that we've seen a bunch of these patients and missed them, and we order a SED rate and it's normal and we say, okay, everything's fine. Does that mean, so tell me why that's not in there, and is that sort of first step not a good step, and you got to use the microphone so everybody hears you remotely?
Okay, I'll come up here. So, I don't have a great answer for that, except that we know that they're unreliable. And we know that so much affects inflammatory markers that to have that as part of their criteria, that then non-rheumatologists will then go out and adapt to evaluate patients who have unknown diagnoses, can leave us up for, can leave for identification of cases that are unlikely to actually be cases. In some of the other criteria, and I suspect that
So let me just clarify. So false positives, but not false negatives?
false positives, but rarely false negatives, although we do see them. I think, the arteritis classification criteria are up for review with the American College of Rheumatology next. They just finished lupus and rheumatoid arthritis. And I suspect what they will add is that inflammatory markers are sustained to be elevated in the absence of other explanatory causes for X amount of time. And that might help, but I think this classification criteria is several decades old at this point, and so they just didn't want to include it as a blanket statement.
And then my second question was, Khusrow, so these drug-coated balloons, how long is the drug present in the vessel wall after you put those in?
So they are using paclitaxel currently, and the paclitaxel, they think in the vessel, and all the data is for atherosclerotic disease in the SFA and popliteal arteries. We really don't have any idea how the drug will behave in inflammatory type of arteritis. And so we have no idea if this will really inhibit the restenosis, which is a different etiology in inflammatory arteritis as compared to, I think out of just lack of better devices of treating this disease, I am wondering if we should be able to put some of the devices, biologic agents on these drugs for this type of disease, but I think it will be so expensive to make those for such a rare disease that it might not happen. So I don't know how long it will stay.
Question I should know, and I've forgotten to answer. If you ignored the location, ignored the age of the patient, and did pathology on these, would it be the same, look the same?
Exactly the same. GCA and Takayasu's arteritis, exactly the same histologically. So you need to have the demographics to help identify.
Other questions? Okay, we're at 8:30, so we'll go ahead and finish, but thanks a lot. That was fantastic. That was great.
The preceding program is copyrighted by Emory University.